Listen-only mode.
Well, hello, and thank you for attending Best Practices and Strategies to Successfully Navigate Healthcare. I'm Carol Fly with High Take Answers, part of the Answers Media Network. We appreciate your time today and look forward to a great event. Before we begin, and I introduce Justin Barnes, our presenter, just a couple housekeeping issues. First and foremost, a copy of the slides in this presentation, as well as a recording of the event on YouTube, will be delivered to you post-event. So just sit back and relax and be rest assured that we will get that information to you. Second, we will leave some time, about 10 minutes or so, 15 minutes at the end of the program towards the end for questions. So please use the question tool found on the GoToWebinar dashboard. If you have trouble using that tool, you can also chat it to me directly, and we'll make sure that we get that in the Q&A process into the fold. Our presenter is Justin Barnes, a nationally recognized business and policy advisor who serves as Chairman Emeritus of the HIMSS EHR Association, as well as co-chairman of the Accountable Care Community of Practice. He is also the popular host of our Healthcare Now Radio's weekly syndicated radio show, This Just In, which also broadcasts on Business X Radio. Justin's an advisor to healthcare providers about optimizing their revenue sources, and he's formally addressed or testified before Congress on numerous times, including statements on value-based care delivery, MACRA, and many other topics. So Justin, I'm going to go ahead and give you control of the PowerPoint and go on mute, and I will see you back towards the end of the Q&A.
Thanks so much. All right, I'm about to hopefully take control here in a moment, but I don't think I have controls yet. Yeah, there we go. Carol. There we go. All right. So I appreciate everybody's time today. We're going to spend about the next 50 minutes or so covering quite a bit of content. And as Carol mentioned at the top of the hour here, we are going to share all of these slides with everybody. And we, again, appreciate everybody taking the time to be with us. And please do feel free to ask any questions or even reach out to us after this talk. We are going to cover a lot of ground. Obviously, healthcare is evolving very quickly, but even just coming back from HIMSS 17, the HIMSS annual conference this year was in Orlando, just more opportunity than ever before. But you've got to engage healthcare, you've got to engage it strategically, and really understand what you have to do as a healthcare organization, whether you're a physician practice, a medical group, a hospital, a health system, a retail clinic, whatever it is, you've got to really look out at different strategies. It's not just about, hey, I've been successful with fee-for-service, but really looking out as how is value-based care going to affect me? How is consumerism going to affect me? How are any changes coming with the ACA or health insurance reform going to affect me? Because all of those are going to affect healthcare pretty dramatically. And so I think it's understandable to kind of put a strategy, a roadmap in place. Again, it doesn't matter if you're a one-doc practice or a 1,000-bed teaching facility or a 1,000-bed health system. It's about really making sure that you have your roadmap and your goals well-defined and that you have a plan to achieve those goals. And you have a team around you that's going to support you in achieving those goals. That's the basic tenet of any business. Doesn't matter if you're in healthcare, transportation, energy, you got to put a plan. And a lot of the practices that in hospitals that I've worked with don't really have strategic plans. Some hospitals and health systems do, but many people don't have the granular plans to get them from point A to point B, certainly when you get onto the practice side. So that's hopefully some of the pieces that I'm going to talk about today, but I am very optimistic. I'm on the front lines of healthcare. I'm on the front lines of policy. I'm on the front lines of providers, and as well as companies and organizations. So really trying to navigate their successful components in healthcare. So as you can imagine, understanding the ACA, the rip and replace, how it's going to affect you. Obviously, we don't know many tenets of that, but I think that we'll see more of that coming up. I'm not going to spend a lot of time on that because this one more is about MACRA, value-based care, and consumerism. But also consumerism is a big piece that people still haven't engaged, at least engaged real successfully. So there's lots of opportunity there. I don't think it's a driver in healthcare. It's not a dominant driver yet. But consumerism will be a dominant driver, I would say, come 2018, 2019, and 2020. So just make sure that you're engaging that. I'm going to talk a little bit about that in a moment, what that means. But also, a lot of you have invested in health IT, whether you're on the practice side or the hospital side. but you got to make sure that you've optimized that technology. But also coming out of Congress and coming out of the administration, you're going to see even more support for provider usability and ease of reporting. I've been fortunate enough to have known Tom Price for about 18 years now. He lives in Atlanta. He's an orthopedic surgeon. I've been able to work with him through the years. And from what I know of him and what his policies he supported and where he is today, even as of yesterday, he's a very strong advocate for care providers, and care providers of all domains. So it doesn't matter if you're a nurse, you're a doctor, wherever you are in that spectrum, he's going to look out for you. And I think that should be a breath of fresh air to the industry. He's also going to ensure there's ease of reporting. So that comes on twofold. That comes from making sure CMS creates the best, most streamlined programs and regulatory components that are possible, but then also making sure that the vendors navigate those programs successfully and make sure that we have that the vendors create the very best innovation, that the vendors create systems that are easy to use and workflow that's easy for care providers and others in healthcare to use. So I think you're going to see pressures on both sides. CMS is going to have to do their job, and the vendors and innovation is going to have to be created on the other side. And look for that. I'm actually very optimistic about that as well. But also, we're going to have to look at revenue and cash management. You've got to do more, but then also you've got to be able to successfully navigate past fee-for-service. The majority of healthcare is still squarely in fee-for-service, and I get that. However, when you look at MACRA, you look at MIPS and the QPP and the Quality Payment Program and alternative payment models, and you've got all these different components, even then PCMH and CPC Plus and all these other ones, it's all about evolution. And it's got to make sure, and we're going to touch on that today, but it's very important that you begin to put an eye out there. And the cool thing is, at least what I see, if you've invested in a top 10 or even a top 20, top 15 EHR and practice management system, or on the hospital side an HIS system, if you bought one of the top 15, you're pretty well positioned to at least begin to succeed with these programs. You got to make sure that you're staying updated, and you got to make sure it's customized to your workflow and customized to how you want to practice medicine. But for the most part, the base functionality is there. And obviously there's a lot of pressure to make sure the vendors come out there with the dashboards that they need and the quality reporting initiatives and making sure it's easy for care providers and hospitals and others to navigate the system-wise. But you got to make sure that you're beginning to engage those programs and that you have updated systems. But I do think there's a positive message there that you don't have to go rip all these systems out. Some practices may have to, but also many don't. And so I just want to make sure that you really evaluate what you've already invested in and look to optimize. Certainly if you've got a top 10 one, top 15, you have to optimize your current investment. I hope that's good news to you out there in the market. And also make sure that you've implemented health IT to improve care coordination as well as manage your populations. And that's better collection and data use. What I mean by that is, again, looking past fee-for-service, you've got to look at how do we have our care plan set up to coordinate care? Are we capturing the right information? Are we actually using that information strategically? It doesn't have to be using all of it, because none of us use all the information that we have access to. But there are certain components and pockets of that data that can help you today. And I'm going to walk through some of that. But you got to make sure that you're always working towards capturing this data, capturing it obviously electronically, storing it, sharing it, coordinating care when possible, having the interoperability that you need, forcing the different players in your value chain to interoperate. It's your data, it's your patient's data. Make sure that it goes where you need it to go. And you can do this inexpensively by looking at some of the big care initiatives out there like Sequoia Project and Care Quality and Commonwealth and there's others. But there's great ways to have data move throughout the value chain. And also, you're going to see more interoperability demands. So it kind of leads you to my next point of, we saw the passage of the 21st Century Cures Act, and you're going to see more demands and more push on interoperability. So now, talking a little bit about from a strategy side before I dive into some of these programs specifically. And this goes for physician practices as well as hospitals. But you got to look at expanding services, maybe engaging new programs, maybe unique partnerships, and ensuring consumers have access to care. Obviously, government has a little bit to do with this, in some cases, in some practices and hospitals, a lot to do with it. But in others, it doesn't. But then the commercial payers have a piece there too. But you got to make sure that your practice or your hospital is set up for consumerism. making sure that you're set up to offer the best services, the most profitable services for your patients, for your customers, for your community. And this is thinking differently. This is not just doing the same old, but there's ways to create partnerships. I'm not saying you sell out, but you can create strategic operating alliances with other groups. These are all, again, standard business practices that we deploy all across markets globally, but you got to look at your practice the same way. You got to say, well, hey, what else can I be able to service? What devices might I be able to bring into my practice to offer a new service? Or what types of new programs? It's not just about what CMS is doing, Medicare and Medicaid, but dozens and dozens of commercial payers, thousands, hundreds, have these new programs that you can engage, quality reporting initiatives that you can engage in and make money at. I mean, we have customers making $10,000, $20,000 a month on patients, and just by reporting quality data to their payers. So it's a great opportunity to begin to look at healthcare a little bit differently. Again, any strategic partnerships or anything like that you can create with other specialties or like specialties or parts of different cities and towns and so forth. Reaching out to some of your local employers and creating unique care models. I've been involved in that for almost a decade now, of large practices or hospitals creating strategic alliances with large employers and communities. There's opportunities for all of that, and it's very exciting. It's how healthcare is evolving and healthcare is shifting. You've got to be looking at risk-based contracts and exploring those and how you manage those. You may not necessarily engage them initially, but you got to understand what risk-based contracts are available to you and available to your community, available to your specialty by your different payers. And we hear about how a lot of practices have sold out and sold to hospitals or other healthcare entities, but now I'm seeing this pendulum effect that a lot of these providers are coming back on their own, and they're choosing to start up new multi-specialty groups or partner with other providers of the same specialty and create a new care opportunity and a care model in a community. So it's not like everybody's just selling off to hospitals or health systems or other healthcare entities. It is kind of neat to see this big pendulum where they did sell out, they're part of the hospital for a couple of years, and they move back out on their own. And sometimes they keep a strategic alliance with a hospital, but it's a new operating care structure in a community, and it's pretty cool. I've been part of a couple of those in the last couple of years. But the reason I want you to make sure that you pay attention to all of these different components and different strategies is because one of my business partners called it the underlying multiplier effect of shifting payment models. As you engage these new care models, word gets out, reputation gets out, your metrics get published, like on the Medicare Physician Compare website. This is going to impact the panels that you're on, the referral streams that you're a part of today or in the future, patients, consumerism. These all are going to affect your bottom line. And so it's not just about, hey, I'm going to not participate, I'm going to keep on doing the same thing. If you keep on doing the same thing on a fee-for-service and not looking at where MIPS or the quality payment program is going or other quality initiatives by different payers, and again, there's hundreds out there, it's going to affect what panels you put on. It's going to affect your revenue streams, your referral streams, your consumerism, the patients, I promise. And so I just want to make sure people are keeping an eye on that. Some of you, about 10%, I think, in the market are really capturing those pretty well and engaging, but 85 to 90% of the market still has a long way to go. And even the education, even if they don't engage, they still got to educate themselves because it is the future of healthcare. There is no going back to a fee-for-service model. There's no going back to a paper-based care model. So I just want to make sure that you're moving this direction. And then again, it's not just about what Medicare is doing with the QPP. That's one of the larger programs, the largest out there in the country today. But Medicaid has programs, commercial and private payers all have programs, and they're all evolving. So it's everybody is moving in the same direction. So also I want to talk a little bit about optimization, efficiencies, and creating economies of scale. So look across your organization and your community to say, hey, what else might we be able to bring to this community? What else could we be able to drive revenue from into some new sources, and also a higher profitability of current sources and current services. So I think that's something that we like to do, and that's something I think just near and dear to communities of success. But number one is you've got to look and optimize your revenue cycle. It's the money that you have. It's the money that you've collected. It's the money that you're working to collect. And it's the kind of the lifeblood of your practice and/or your health system. So it's very important. And what does it mean to optimize? I'm going to talk about that in a moment. but you got to really take your revenue cycle, because you might be able to go get access to more patients, more money, more revenue, which is fantastic, and that exists certainly. But you also have got to optimize the money coming in and making sure that you're getting paid. You're getting 80, 90, or 100% of the money that's due to you. It's very important. Don't stay at 50, 55, 60%, which is pretty common across the country now. But you have access to collecting. There's so many things that you can do to increase revenue by 5, 15, or 20% and get closer to where you need to be. Making sure that you're closer to where you need to be on the cost per claim, and I'll talk about that in a moment as well. But look across new services, care delivery opportunities, and what specialty-specific programs might be available to you. They're out there all over. So, and this is something, again, that we conduct, and we go out there and do these surveillance of communities and pull them to you, but it's exactly what we want you looking out for. Also, make it easy. And this is a business practice across all industries, not just healthcare. You got to make it sure it's easy to conduct business with your organization, whether you're a practice, retail clinic, a hospital, health system, whatever you are. Make it easy to do business with you. So align your processes and your services and innovation to ensure that patients can easily schedule appointments, easily get someone on the phone to schedule appointments. They're trying to come in and give you money. But 50% of practices in the country, and even hospitals, are difficult to get on the phone, difficult to schedule appointments with, and difficult to be seen. Well, that's not a good long-term business model. It's okay today. It may be okay today, but I promise you're leaving a lot of money on the table. But you got to make sure it's easy to schedule appointments. It sounds very simple, but in practices and hospitals across the country, it's very difficult today. It's very frustrating for patients. Patients are consumers. And that's what I'm saying. Consumerism is really going to pick up. And so you got to make sure it's easy to access scheduling appointments, and come in there to be seen. Harris came out with a survey recently that talked about if a patient waits more than 25 minutes in the waiting room, it begins to have a direct effect on their feeling, the belief of their care quality. Doesn't matter the results of the care quality says. It says if that patient sits in the waiting room for more than 25 minutes, they begin to feel there's a decrease in their care quality. Again, it doesn't matter what the results were. It's interpretation, it's feeling, it's perspective. And that's very important, certainly when 5 to 15% of our future pay models are based on patient satisfaction. MIPS has components of it. We all know hospitals have a component of it already. So you got to make sure, just the waiting room, navigating that hospital, navigating that practice. And when I say navigating, there's lots of components to navigation that are very important. Can be more important every single day. And also make it easy to make payments. There's so many solutions out there that have easy bills, easy to understand, easy to pay. They accept credit cards. You can do this all online. Very simple ways to understand your bills, getting clean bills in the mail, and paying on a timely manner. And also collecting payments at the time of service. Certainly collecting copays. I don't even know the number. I think it's 55 to 60% of practices don't force or don't even process copays at the point of the visit. So now you've got to pay someone else to go help you chase that money down afterwards. And it takes 2, 3, 4 months, 5 months to get that copay. Collect that at the time of the point of service, the time of service. That's just one of the best practices. But also make it very easy for patients to pay their bills as well. So very important also, understand and manage your cost structure. So when I say that, you got to make sure that you understand what things cost. Hospitals do an okay job of this. Practices not so much, and you really got to, and it's not just about what the practice and what you guys do on your end. You got to push other people for more transparency on what things costs. And whether it's Medicare's doing a better job, but what things cost, being the commercial payers need to start opening up some more. They're having more transparency on their side, but you really got to understand what a procedure costs you, or what a visit will cost you. Because if for a 91214, if it costs you $250, but you're only going to get paid $210 or $190, well, you can't go at risk for that visit, or whatever the visit is. There's thousands out there, but you got to understand what your cost structure is for a certain visit. And the majority of practices they see the same 8 to 20 different visits. So you really understand what those visits are, because those are the ones you're going to go at risk for in some of these contracts. And if you know you can perform the visit at $200 or $160, but you're going to get paid $190, well, you can make $30 on each visit, each service. And that's the stuff you got to look out for. So that's something you got to understand your cost structure. You've got to streamline operations, increase throughput. This is where really getting some help on the revenue cycle side can help you. You can repurpose some of those resources to revenue collection and navigating some of these new care models, because you're going to need some assistance on that side of the house. So we're getting some real good revenue cycle experience and expertise in there. You really need to be able to achieve more with less, and that's 100% possible. I promise that. Cost of operations have increased 50% over the last 10 years. But I promise you, your revenue has not for those services. So just something to keep an eye on and think about. But you've got to look at how can you achieve more with less. Understand your current staffing model. Again, when you look at some of the revenue cycle items and you look and say, hey, how can we really focus on new wellness, new care coordination, and pop health activities? You know, that's really something that you've got to keep an eye on, because you can't exactly keep hiring and adding on more resources. It's how do I do more with our current resources? And also, when I look for automation and co-source opportunities to improve your economies of scale, basically doing more with the same or doing more with maybe a little less. Reduce your cost per case. Again, those are opportunities that you can certainly do. Leverage innovation internally and externally. You've already invested a lot in technology. Optimize it. Something that's, again, near and dear to my heart. And implement clinical, financial, and administrative best practices. It sounds simple. When I say clinical, what do I mean? I mean setting up the dashboards to see exactly how you're doing within this certain care model, or within MIPS specifically, that you've achieved the criteria to get to your 6 measures, your 6 criteria in quality, or whatever it is, whatever you're shooting for. Make sure that your AR, your days in AR, is where you want it to be. There's so many components of your revenue cycle. There's so many components of your care coordination, and so many components of these new quality programs that you can monitor via dashboards, but people don't set them up or monitor it or have the right expertise. That's all the kind of stuff that, again, that I do, that near and dear to my heart, is getting in there and setting up the EHR to capture this information at the point of care. It's not about all this back-end reporting. That is important to do. But then also setting up the EHR to help you navigate these models. That's all available today. I'm about to walk through some of that. But before I dive too deep on the clinical side, let's go into the revenue cycle and really how to optimize your revenue cycle for quality payment programs. And I don't just mean, again, CMS. When I say quality payment programs, I mean generally across the entire healthcare industry. Medicaid's got quality payment programs, Medicare's got them, and all the commercial payers have them, in almost all of our communities across the country. But people don't ask, people don't engage, you may not know about them. And I'm going to kind of close with that aspect, and I'll tell you how to kind of understand what's available to you. But really optimize your documentation because it will mitigate issues and it will reduce your risk. And so what I mean by that is look at your provider workflow, make sure that you have your EHR is customized to exactly how you want to practice medicine, that you use templates where you need to, and you really look at how can I create more efficiency, have a much more streamlined process when I'm using my electronic health record. I'm giving my patient the best care, the base visual that you're actually with the patient, but also you're engaged in that technology. There's a lot of best practices in there that can help you. People say, well, I'm sick of typing on my keyboard because I feel my patient's getting ignored. There's ways to do both. There's ways to document care, provide premium care using technology, but then also give that patient the ultimate experience. And just best practices, and that's stuff, again, that we help with. But also you want to look at your documentation and notation, because we want to reduce risk here. There's lots of exposure for risk. So there's under-documentation, but also risk of not getting paid for what you did. There's assessments that you do, there's questionnaires that you give, there's evaluations that you do, there's services that you perform, tests that you give, and screenings that 35% of care providers do not even document, and they certainly don't get paid for them. The money's being left on the table. So beyond the money, also every one of those pieces will count you towards your MIPS scoring or scoring part of other quality payment programs. So it's like a double win. It's, you get paid for what you do, you get paid for those assessments, part of your everyday business, but then also you capture it and you can report on MIPS. My goal is to have practices not only stave off that 4% cut, but go for a 1, 2, 3, or 4% increase. It's not too late. You can still go for your full 4% increase under the MIPS program. and be successful. So another best practice is random chart audits, looking at really 10 per provider, monthly or bi-monthly, and have somebody else go in there and whoever from outside. A best practice is to get an outside person who does not do it every single day, because most people can't see their own mistakes because they don't know. This is what got me into the revenue cycle side of the business, is the excitement of, I understand ICD-10. I know how all these payment models are evolving. Well, that's exactly where you need to integrate that all into your revenue cycle, into your documentation. If you do that, you can thrive. I promise you. There's so much opportunity out there. But most people don't know that. And certainly a lot of the current staff on the billing side may not be experts in that. They don't know exactly how the quality payment programs are evolving, or CPC Plus, or any alternative payment model, or even all the complexities that are rolling out and continue to roll out with ICD-10. And the revenue opportunities within ICD-10 are tremendous. So you also want to look, when you get an expert biller in there, an outside set of eyes, look for missing charges. So looking for consultations, looking for no notes, wrong provider noted, down coding, up coding, wrong ICD-10 codes using, missing modifiers. All of these prevent rejections, denials, and audits. And again, when we look out and we basically guarantee 5 to 15% additional revenue when we work with a practice or a hospital. And 35% of the revenue that we find is right here. Because we're going to go out there and not only appeal, and also a best practice is appeal 100% of your denials. And the average practice only appeals 60% of their denials. Practice managers don't usually know that. We appeal 100% of those denials. You need to be appealing 100%. But then also, you need to have strategy to go after root cause. So we use a lot of our formularies to go after the root cause. That's the important thing. It's not just about going after the same and knowing how to appeal each one of these denials. It's about going to the root cause and stopping those denials and just getting them paid on first pass. But again, only 60% of practices do that. And less actually have a strong root cause strategy, 31%. So again, there's so much money that's being left on the table here. And you've already heard from me, but keep the future in mind. You want to optimize your coding and make sure you're using the right ICD-10 codes that integrate and match the payment model that you're going for. And have that inside your electronic health record, inside the EHR, inside the templates that you're using. Because it'll automatically do all the calculations in the back end and create all that dashboard that you need to see that you're being successful or that you're not quite hitting your metrics, and we'll go in there and we'll tweak it. You got to do that. We do that every 2 weeks to every month with our practices, depending upon what model they want to go for and how much incentive they want to go for. But you can do this for PQRS, for MIPS, for alternative payment models in general, and quality reporting initiatives across the board. The other area where there's money left on the table is fee schedules. Less than half of practices audit, and hospitals, audit their fee schedules to make sure they're actually getting paid based on the contract that they've negotiated for that year. We do a financial analytic review every 6 months with most customers, but some every 12 months. But that's very important because there's always money left on the table, and it's always 98% of the time in favor of the payer. The practice is owed money, and we go back and we collect it. So just make sure that you're doing that. Manage the fee schedules. Don't take them for granted. So now shifting over to value-based care, incentives and some initiatives here. Everybody's very well aware, I'm sure, of MACRA, MIPS, and these alternative payment models. So I'm going to fly through that. But the options, again, a lot of practices that I engage, I know you guys have all seen this information before, but a lot of people are just going for option one. They're just trying to stave off that negative payment adjustment. But I'm telling you, with a little bit of effort and a little bit of expertise, you can easily go for option two, which is really trying to get 1, 2, 3% increase. Or option three is we can go back to January 1st and collect for a full 365 days and get a 3 or 4% increase and go for some bonus dollars as well. So I'm hoping that everybody, because option one is very simple to pass. But first of all, as a baseline, please do not ignore MIPS in this program, certainly if you qualify for it. If you have more than $30,000 in charges, make sure that you're going for the program because A, it's going to 2018, I promise you, is going to be a steeper hill. And if you engage it slowly now, or even engage it full bore, you can be much better positioned for when 2018 and 2019 hit. You can begin to go up that mountain with it. If you start in 2018, you would have got a pay cut. Even if you qualify for the program, if you don't qualify for the program, I still recommend getting some expertise in there and setting your EHR up, setting your documentation up, looking at what 2018 could mean for you, because they're going to broaden the swath come 2018. More people are going to qualify for the program. And it's going to be a steeper hill. So I just want to make sure everybody's beginning to engage the program. Even if you may not qualify for it today, there's a chance if you're participating in Medicare at any level in 2018, it could grab you. But probably many of you on the line right now, or I know many of you on the line right now, do qualify for MIPS. So please at least engage option 1, but please option 2 and 3. Or you might be part of an advanced alternative payment model, which is terrific, or you're going for that, and that's great. Because all of MIPS is a stepping stone into AAPMs, advanced alternative payment models. That's where CMS is pushing everybody. But MIPS is just kind of a stepping stone. Again, I'm not going to spend a whole lot of time here. Everybody's seen these graphs. They've been out for almost a year and a half now, so I'm not going to spend much time on it, but it's the obligatory slide I've got to add in, and again, all these slides will be available to you afterwards. But the biggest thing here is the money starts off small, but 4% is a lot of money. I don't want a 4% pay cut, and I certainly want a 5% increase come year 2, and 7% in year 3. I want that money. You deserve it. It's also how all of healthcare is evolving. So it's got to make sure that you understand the opportunity and you kind of go for it. So again, I'm sure a lot of this is redundant because we talk, these slides have all been out there in some form or fashion. CMS has been talking about this program for at least the last year and these components, but quality, up to 6 measures. And I promise you, when you look at family practice, there are 55 measures to choose from. You only need to report 6 to get your max credit, which is 60% of your total score. For cardiology, there's 20. So what an expert partner like us, we'll go in there and look at your specialty. We'll look at how you practice medicine. We'll look at your PQRS and what you've done before. And we'll go look at what, even if you haven't done PQRS, we'll still look at your documentation. And we're going to go pick, of the 20 for cardiology, we're going to go pick the 2, 3, 4, 5, or 6 that are best for you. And let's go report on those. And let's get you max money. So that's just the best practice. A lot of people don't realize this is actually very simple. Certainly if you've done PQRS or you've done meaningful use, you're going to be very well positioned. Not just to stave off that 4% cut, but to get a 1, 2, or 3, or 4% increase. Advancing care information, looking at the 4 or 5 criteria there, depending upon if you're using an EHR, a certified one for 2015 or a certified one for 2017. But if you've done meaningful use before, you're going to be very well positioned for this. And this is 25% of your score. And then improvement activities. You have 93 to choose from. 93. And you only got to pick 2 or 4, or even 1 or 2 of your less than 15 providers in your practice. So 1 or 2, medium-weighted one or high-weighted one, and you get full credit. Or if you're a larger practice, 2 or 4. But again, so much opportunity. 93 to choose from. So much opportunity to go through. And you're going to see improvement activities grow certainly in 2018 and 2019. You'll see some of the quality weighting go down a little bit, and you're going to see improvement activities weighting go up. Right now it's only 15% because it's a new category. So CMS want to be fair. But it's improvement. It's showing outcomes improvements. So you're going to see that component increase, and also going to inject in there the whole value-based modifier for 2018. So one thing I speak to a lot of rural health clinics and federally qualified health centers. Just so you know, if you are an RHC or FQHC, you can voluntarily participate, but you're not required for 2017. And you're not subject to the MIPS adjustment. However, if you do bill traditional Medicare Part B versus the all-inclusive rate, you will qualify if you bill more than $30,000 in Medicare Part B. So just because you kind of fall back into the traditional Medicare provider in that regard. So I want to make sure I touch on that. That's been a confusing part out there in the industry. So with MIPS, and I know people do specific webinars on MIPS, and I do specific. I got a bunch posted, and I do a lot of just on MIPS, but this was more about strategy in healthcare and how to be successful. Everybody's doing webinars on Quality Payment Program and MIPS, including me. But this one today was different. We wanted to make sure we focused on strategy, how to be successful, best practices to deploy. Obviously, MIPS is one of those best practices, but this one is a little bit higher level. So if you want specifically to see my webinar just on the QPP and just on MIPS and APMs, let us know, let Carol know, and we'll send it to you. We'll send you a link. But the takeaways for MIPS and the Quality Payment Program, certainly with CMS, as it relates to CMS, it's pick your pace. You can report for 90 days, you can report for 150, 180, 270, 360, 365, whatever you want. It's up to you. All of that will stave off your 4% cut and begin to put you on a road to a 1, 2, 3, or 4% increase in 2017. Highly flexible. So every single specialty has numerous criteria to choose from. Like I said, cardiology has 20 different criteria for the quality segment. Family practice has 55 to choose from. Internal medicine has 37 criteria to choose from. So much flexibility across all these different specialties that you pick what objectives and measures are right for you, best fit your practice, best fit your specialty, and best fit your workflow. And it's not all or nothing like we know meaningful used to be. You can get partial credits, you can get bonuses available. So, you know, all of this is, I think, CMS, for what they're trying to accomplish, did a very good job with the first year. Keeping the bar very low so people don't get cuts and you just totally ignore the program. All you do is report on one quality measure or report on one improvement activity or the Advancing Care Information ACI measures, one of those items to stave off that 4% cut over a 90-day period. It's extremely simple, but it's so simple that I want to make sure you go for a 1, 2, or 3, or 4% increase. Because again, it's about the money, but it's also about positioning your practice perfectly, or your hospital and your community there, for how healthcare is evolving. About 2 months ago, I published a 4-point plan and success best practice document in Becker's Hospital Review. So I talk about financial success and how to stabilize and optimize current revenue streams and create new future revenue streams. How to achieve clinical success, so focus on documentation, population health and care coordination, technical success, how to optimize your current investments. Not about going to spend all this more new money and all this kind of stuff. Sometimes you might have to, depending on what you purchased in the past, but optimize what you already have invested in and what functionality enhancements that you can insert or turn on or optimize to create a successful infrastructure technologically. And then also how you align your staff, how you get the right expertise inside your practice or your hospital, and how you involve everybody rowing in the same direction, and how you want to create a constant educational stream, an educated environment around healthcare's evolution, and how your practice, your hospital, your health system, your community is going to be successful. So that's what this, there's a link to it right here. You can just type in 4-point plan and adjust it, and it'll come right up in Google or Safari or whatever, but we have to link it to you. But it's pretty good. It's pretty detailed strategy, and it's a blueprint for, again, practices and hospitals of all sizes. Here's an example of something, again, about 7 years ago, me and my team went out there, and we realized that value-based care was far beyond what CMS was doing, Medicare, Medicaid. But we have programs almost in all, even at that point, we had programs in all 50 states almost, whether it was very simple PCMH, patient-centered medical home, or, again, oncology care models, whatever it was, CPC, CPC Plus, all these different care models and across all different states. And sometimes by the state, a lot of times by the payers, but again, outside of what CMS was doing. So I wanted to just highlighting a few here as examples, because this is part of the surveillance. I call it a community and industry surveillance that we do for all of our customers. And you don't need, I mean, you can do this on your own. You can go out there and find out what Humana is offering, or Aetna, Blue Cross Blue Shield, or Cigna, or whomever. What programs are out there, and obviously it's important to know what CMS is doing as well. I'm going to offer you links to all of this here in a moment. But understand what is evolving, what is occurring in your community outside of just CMS, because there's lots of money. There's a lot of money out there that you can go look for some success. So again, what will it take to succeed financially? Pay very close attention to your bottom line. You can't relinquish any of the money that you currently have. Everybody in your practicing hospital is working very hard, seeing patients, providing high quality care. Bill for it and ensure you get paid for it, and collect that money expeditiously. Make sure you're optimizing your operations and making sure that you have clinical as well as financial health. You want to pay close attention to the nuts and bolts of your business. So you want to optimize and create comprehensive coding. You want to look at claims, claim creation, scrubbing, and submission. First pass, 99%, 98%. That's where you need to be. And if you're getting rejections, you're not getting those claims processing and clean claim through the first time, greater than 95, 96, 97%, you need to get some help in there. Denial management, I talked about this, looking at root cause. It's not just about appealing your denials. It's about going in there and finding the root cause and mitigating that so that denial does not occur again. Eligibility verification, so critical. It becomes more critical every single day for that patient to make sure that you're going to get paid for that visit, and that consumer, that patient's eligible for the service. Authorization management, prior authorizations. Again, don't get stuck with a service that you've rendered that you're not going to get paid for. Look at and pay very close attention to payer contracts and the variance rates in those contracts. And that you go after money, or you have a partner or somebody that goes after that money for you. And set up KPIs, key performance indicators. We have them across all of our businesses. It doesn't matter if you're in healthcare, transportation, education, energy, whatever you're in, set up KPIs. You can do it as a 1-doc practice, you can do it as a 50-doctor practice, and you can do it as a CFO of a health system. But everybody needs to understand how they're doing financially, how they're doing administratively, and how they're doing clinically. So talking about clinical, you got to make sure that you're integrating data from your clinical sources and your financial sources. This is why, I've chosen to focus on the revenue cycle and integrating all these new care models into the revenue cycle. I've been doing this now for 3 years because this is how you're going to optimize. If you're going to be successful with these new care models, there's not betting on the come. You can see exactly how you're going to receive your revenue, where you need to focus your efforts, and how you need to shift what you do and how you provide care today. You begin to shift to ensure you're successful with these new models coming at us. Again, customize your EHR, create the dashboards that capture, monitor, and report on all the key measures and factors. This is very important for people. We really started that under meaningful use in the clinical side, but you can do it for PQRS, and you need to do it for MIPS and alternative payment models. You want to set up these dashboards, you want to monitor them at least weekly, bi-weekly. Something like us, we'll actually come in and look at them for you and tell you what's looking good, tell you what we got to go in there and modify and fix, and where you might be falling short. But make sure that you're doing that as well, or you get a partner like us. That's just a very key aspect to this. But again, practices can do this on their own if they know how. And as you've heard numerous times, implement best practices where applicable to optimize your opportunity. There's financial, clinical, and administrative best practices. Even, again, I talked about making it easy to schedule. Make it easy for patients to navigate your practice. Don't make them wait more than 25 minutes. Make it easy to pay their bills. Make sure they're reminded of their visits. They get reminders electronically. Again, these things cost pennies on the dollar, but they bring so much ROI. They allow you to successfully navigate where healthcare is going. And the best practice, again, you heard at the top of this webinar, is to look out and how can I evolve? What can my practice do? What can my hospital do? How can I, a hospital strategy that I've helped create here in Atlanta is the hospital looking out and creating urgent care clinics throughout their community. It helps with ER visits. It helps with additional revenue streams. It helps provide primary care to that community. There's so many different strategies. Practices are doing this. I've helped practices partner with corporations to be their first line of healthcare. Well, the first practice to do that now got an extra couple thousand patients. And these are patients that are on a single plan. These are patients that are being educated about their care. These are high value patients that you want in the future. They're beginning to take care of themselves. They're becoming true consumers. They're managing their care. They're following their care plans. They're taking their prescriptions. They're adhering to their care plans. This is exciting. This is where a lot of money can be made, a lot of opportunity. Again, these are just a handful of best practices that are out there. Every practice has access to different care models or different strategies to be successful. Create a monthly scorecard to review your clinical aspects and your financial aspects. Red light, green light. I was part of a health system here in Atlanta that every Monday morning, they look at their patient satisfaction scores. And they have a great reputation, but they want to keep that reputation. And they are an amazing hospital to work with. But you know what? And why? They put patients first. Truly put patients first. They care about their patient satisfaction. They drive their entire organization from patient satisfaction perspective. And they're thriving. I know top down because the CEOs are my best friends too. So I know they're doing very well. It's exciting. It's a fun environment to work in and to help out. In care coordination, it's going to be a key point. It doesn't matter what your specialty is. Coordinating care among specialists, coordinating care among primary care groups, amongst communities, is going to help everybody be more successful and drive more revenue. And then really looking at opportunities for patient engagement, educating patients, creating an educated consumer, and empowering the consumer. So with that, I truly personally believe that all care providers that intentionally and deliberately engage with new payment and care delivery models and create the right partnerships will have more opportunity in the future than they have today. And this is me. I created this statement, and I truly believe it. And coming out of HIM 17 last week, I know this to be true, even at a greater level. Here are a couple resources. Again, all these slides will be available to everybody. Let us know if you have any questions. But the QPP website that Medicare created is the best website I've ever seen come out from a government organization, ever. And I've been working on Capitol Hill for almost 20 years now. Phenomenal site. Go pick out your specialties, pick out how you might want to engage the program, and learn. It may not offer the best practices, that's stuff that kind of like I offer and we offer, but it's a great website. Our website is next, iHealth Innovations, a lot of best practices, a lot of educational webinars and seminars on how to go ascertain new revenue sources and optimize your coding and revenue best practices. All that's out there. All the QPP documents or all the QPP webinars are out there. The innovation.cms.gov, another great website to see what is happening across the country. CMS shows promotes all of their programs through that, but they also have a lot of the commercial programs, and also the public-private collaborations are out there. And then at the top of the webinar, I talked about Medicare Physician Compare. They're going to start highlighting success in not only meaningful use, they've been doing that for a while, but they're also going to document and show success with MIPS, what care providers are being successful, quality success rates, outcome success rates, the advanced payment models, where what providers are participating in what. And over time, it's going to get more granular and more granular. So it's just cursory information out there today. But in 2018, 2019, 2020, it's going to get ramped up. So know what information is being published out there and what spotlight is being put out there. So with that, I have about 10 minutes left for some Q&A. Carol, you want to come back over?
I sure am. So you're right on the money. We've got about 10 minutes. We have gotten some questions from our audience. To let everybody know, if we don't get to your questions, of course, please reach out to Justin. He's provided his information here, including his email, justin@ihealthinnovations.com, and his two Twitter handles, @HitAdvisor and @RevenueSherpa. Justin, that was a great presentation. So I'm going to dive right in. And first question. Do you think MIPS will require a full year reporting for 2018, or will they have flexible options like the 90-day reporting period like they do in 2017?
That's a great question. And again, Tom Price is going to he's going to put his team on 2018 and any changes that need to happen. But my gut is you're going to have, if you're engaging the program for the first time, for some reason you were exempted for 2017, I believe you're going to have a 90-day reporting period or maybe 180-day reporting period. It'll be a slower uphill climb if you're new to the program. If you've already participated 90 days in 2017, or you qualified in 17 and chose not to go for the program, I think there's a high probability that there is the full 365 days of reporting. But to be honest, I don't know if we will know that until we get into 2018 a little bit, because we're going to have to, or even later this year, we're going to see some of the feedback, some of the struggles the industry is having. But I would be prepared for a full 365 days, but maybe they may offer some flexibility. But I believe they're going to push towards getting people onto this program. Even if the bar is still low, you still got to report for 365 days, but keeping a low bar.
Right. And actually I've seen this question pop up in some other events. How does MACRA fit into hospital-based clinicians? Actually, that was a kind of a conversation at HIMSS too, which of course there are a lot of hospitals there. So certainly,
for the employed practices, for the employed practices and the community practices, it's very viable.
Right.
It's not Part A, but if you're part of the Part B in your community, in a lot of hospitals, and that's what I work with hospitals today, that they have a lot of community clinics and practices that they support in one fashion or the other, or have a strategic alliance with. So that is very relevant to them.
How does, but you're right, Medicare Part A versus Part B, and I think that's where they're, yeah, right. How does chronic care coordination go hand in hand with MACRA?
Well, I mean, a lot of the components, first of all, going for CCM is a great strategy. Because actually, you start going for CCM, you're going to be well tuned for success with MIPS. So there's a lot of overlay in the criteria. There's a lot of overlay in the care coordination. So a lot of what you do part of CCM is almost perfect. It's perfectly aligned with where MIPS are going, and even alternative payment models are today. So they're very well integrated, and that's something that we've worked on over the last 10 years. There are all these different programs coming out from CMS. Let's get them integrated. So let's look at PQRS, meaningful use, CCM, and make sure that we're all moving in the same direction. So, and we are, and they are.
You actually talked about consumerism very early on in the presentation. What role do you expect consumerism to play on future value-based models? Specifically, to what extent will it impact our revenue?
Well, depending upon what program you engage, or if you're a hospital or practice and your entity, 5 to 15% of your revenue today could be tied up on, at least 5% could be tied up with patient satisfaction, 5 to 10%. And I expect that in these new value-based care models to continue to increase to up to 15%. Just patient satisfaction alone. But consumerism has, people think they wrap up consumerism and patient satisfaction, which is a good piece. But also, consumerism is about patients having choices of where they want to seek care, when they seek care, and how they seek care. That's consumerism, and that's what I'm saying. Make it easy to conduct business with your organization. Make it easy to pay bills, be seen, make appointments, give you money. That's the art of business in a lot of ways, and people don't see, they see them as patients. Don't see them as patients anymore. See them as consumers, lifeblood of your practice, lifeblood of your hospital, and that is slowly occurring, but we need to continue on that direction. That's consumerism.
Right, the retail experience, right?
Exactly.
Right. How do you think MIPS reporting will be done for organizations with multiple EHRs? Do you think it'll be a manual blending of all the measures? That's an interesting question.
That is where you're going to have, if you're going to have to set, how we've tackled it is we created an enterprise data warehouse so we can pull in this data from multiple systems and we can view it and we can report it. So you are going to have to look at this data across. For 2017, it's fairly simple, but as you start to become or need to become more high performing and report more, from automation, then it is going to be more difficult. But I do think you're going to see some type of centralized warehouse where you get to pull this data in, visualize it, see what you're capturing, and then report up through your registry or through your claim. So it's going to get more difficult moving forward if you don't have a good centralized approach. But if you're large enough to have multiple EHRs, you do have some data strategists and clinical analysts who will be able to do this. So I don't think it's going to be burdensome for those organizations. That's how they operate. That's how a lot of healthcare is going to operate. It's not just about what CMS reporting is going to be like.
Right.
You need to do this for care coordination, period.
Right. Our practice will likely report for MIPS test option for 2017. Which measures are the easiest to avoid the negative penalty?
Easiest one is to look at, number one is look what you did for PQRS. Look for that measure inside of your specialty for the quality side, and that's probably the easiest one. This is one of the things that you've already been doing. So say for family practice you have 55 to choose from, just go through them and look at whatever one that you've already done or you do on a daily basis. It's really depending upon what specialty you are, so there's not one answer, right, in my opinion, because what's easy for some may not be doable for another. But just it's that simple, is to look at the 55 measures. You can go to our website, you can go to QPP, and pick out of those 55 measures, you know, which one is best fit for you. If you're family practice, if you're cardiologist, there's 20 to choose from. Internal medicine, 37. Gastro, 12. I mean, all the specialties have got a lot to choose from. So that's my advice.
And of course, it's practice to practice too. Obviously, what might be right easier for one practice may not be easiest for
exactly.
Right. When do you have to choose measures? Is there a deadline for choices?
Not necessarily. Well, you need to make sure that I would say middle of the year is you want to make sure you're having some of these, because you have to report for 90 days. So it's really not a deadline, but do not wait until September to kind of pick your measures. I would look at this. I would look at it now. I mean, I'm working with people now, but the latest is July, August to go pick out, you know, the measures that you may want to report on for the last 90 days. But I don't recommend waiting, because too many opportunities for mistakes if you start October 1st. I think it's dangerous.
Yeah. Well, you know, this whole idea of picking your own pace doesn't mean you should procrastinate. I mean, it's just, you know. Correct. Right.
Don't. He just wants to simplify the reporting and documentation burden the first year.
Right. Exactly. Yeah, right. Exactly. So I've got time for one more question, and then we'll have to wrap up. I will remind everybody who's chatting to me that we will get a copy of the slide deck and the recording out to you. Certainly by probably Monday. Give me time to edit that. Okay, the measure documenting current meds in the medical records, since that is a topped-out measure, would you recommend clinicians not use this one? Another question related to measures.
Say it one more time. I didn't quite follow that.
Yeah, the measure documenting current meds in the med record, since that is a topped-out measure, would you recommend clinicians not use this one?
I can't say yes to that off the top of my head, because, again, it really depends on your workflow and how you practice medicine and what information you have access to quickly and simply. So I probably can't give that opinion. If it's difficult for you as a practice, then I would skip it, because there's plenty more that probably aren't difficult.
Right. So, there seems to be a lot of confusion about which measures they should choose, and certainly I guess what I'm hearing is you're saying go look at them and see what you're doing now, and then pick the ones that are currently you're familiar with or would be the easiest hurdle to overcome.
Right. Again, this is kind of why I created iHealth and why it's what we do. We'll go in there, we'll audit workflow, we'll audit documentation, and come back and say, here, these are the ones. I mean, that you want to choose. And it's not that difficult. It's certainly if you have an eye for it, and I've been part of MACRA, testified on it 4 times in front of Congress. So I know, you know, that's kind of the expertise that the lens that I see all this through.
Right. Great. And with that, Justin, good advice for you folks out there who are confused. Please reach out to Justin. Please check out the website resources you recommended, including iHealth Innovations. We will again get the slide deck and the recording out to you. Justin, thanks so much for a great presentation, and hopefully we'll see you on a future event.
You will. Thank you so much, guys. Appreciate everybody's time.
Thanks all. Bye-bye.